requests from some of our members that couldn't make it tonight. So we are going to record this session and play it back for them and see how it looks. But welcome, everyone. This is wonderful. I wish we could see everyone in person. Perhaps that'll happen shortly. Just a couple quick announcements, if I may, before we get going. Our March 4th class is on schedule. Right now we have 12 students enrolled. Class begins on March 4th. If anyone has a couple of more enrollees, we can hold up to a 14 student class. We can't go over 14 because of the social distancing and spacing in the classroom. So if anybody has a couple of more people that would like to join, have them fill out the application online and get it to me as soon as you can, or as soon as they can, so I can get them registered and on the book so we can get going. Again, it's nice to see everybody. I wish this was something we were doing face-to-face in person, but due to circumstances, as we all know, that's not possible at the moment. So Jack and I have been working on the program for a few days and going over the slides and making some corrections and some adjustments so it looks good on a Zoom. So with that, if you have any questions as we go along, please feel free to ask. If anybody wants to follow along, the slides are pretty much taken right out of the manual. Section 3, Chapter 3, which is MedOps 1.
Gracie.
Starts on page 3.1. So, I mean, if you're interested in following along and you have your book, feel free to do so. If not, let's get going.
It's okay.
Of course, tonight is medical block, the 3 killers, the life-threatening conditions that are more important to us than just about anything when we do our triage. Triage we'll save for another day. The objective of this class, obviously, is to review and advance the skills and knowledge of James City County CERT members in medical emergencies. And we're going to be emphasizing on the professional interaction between CERT and patients in an emergency situation. That's our objective for tonight. We'll talk about turnover and command and stuff like that in another session. We're going to try to plan these on a regular basis for as long as they don't allow us to have our group meetings. So we'll try to do a Zoom every now and then, and we'll work on it from there. Right, tonight we're talking about the life-threatening conditions, the 3 killers. Of course, it's airway, bleeding, and circulation or shock or circulation, whichever way you want to say it or how you want to put it, it's all the same. And again, if you want to reference, it's Unit 3, Disaster Medical Operations Part 1. If you want to follow along in your book, you can. If not, let's roll right through it. Just remember that our mission is to provide the greatest good for the greatest number of people by conducting simple and rapid triage and rapid treatment. START. Simple triage and rapid treatment. And my next one that I'm planning, and I started working on slides already, is about triage, which goes into the next section of our book. So that should be interesting also, if you want to join us. Again, it's great. I have, 32 or 33 people. This is wonderful. I appreciate it. Okay, let's get into the 3 killers. And of course, the need for CERT members to learn about disaster medical operations is based on 2 assumptions. One is that the number of victims could exceed the local capacity for treatment. In James City County, what do you think the possibility of that is if we have a major tornado or hurricane?
Definitely.
Definitely. I think that with the capacity that we have, even though we have 5 stations and there's a 6th one being planned, but that's not going to be open now until probably 2027 due to budget constraints because of COVID. But if we had a major disaster in James City County, we have a number of healthcare facilities. We have a number of nursing homes, memory-based facilities, schools that would take precedent over neighborhood associations and neighborhood areas, obviously because of the need for power, electricity, refrigeration to maintain medication, oxygen, and treatment for a lot of people. So by the time they get here, it could be a day, could be 2 days, could be 3 days. So that's definitely a possibility in any municipality. And the problem is if we're busy, York is probably going to be very busy. York County, New Kent's probably going to be very busy. City of Williamsburg's probably going to be very busy. So there's a limited number of resources we can depend on outside of James City County. Now, that's not to say that resources could come from locations greater than that, like Newport News or Charles City, but the response time to our area is going to be delayed. And then, of course, what was the damage to the infrastructure that would allow them to get into James City County to help us out if we needed it. So that's very important. The other thing is that survivors will attempt to assist others, and CERT members will need to know life-saving first aid and post-disaster survival techniques to separate the two. Of course, you all know the history of CERT started in LA when the LA teams went to Mexico, and hundreds of people were hurt trying to save those that were injured because they were untrained. And we're also going to have the same problem here. So they can be an assist to us, but they can also be a large hindrance to us as we try to do our work in a disaster. Time is critical. The golden hour. We use this a lot in the fire service and the EMS service. When the call comes in until we can turn the patient over to a higher medical authority, in our case, the emergency room, we try to keep it within an hour. That's especially important when we have blunt force trauma, crushing injuries, automobile accidents, where we have to extricate people. We still try to keep that hour, that golden hour in time. If you listen to the radios, if you scan our frequencies with stroke patients and trauma patients now, you will hear the communications division or the dispatchers will tell the incident commander what their clock time is, and you'll hear that. She'll say shock clock is at 5, or shock clock is at 10, or trauma clock's at 5, or trauma clock's at 10. That knows he's 10 minutes in or 15 minutes into his golden hour. So that's critical. And that's critical because we have 3 phases of death that occur, not the 3 killers, but there's 3 phases. Phase 1 is when death occurs within minutes as a result of overwhelming trauma, blunt trauma, traumatic injuries. And we have phase 2 when it occurs within several hours. And a good example of that is excessive bleeding. And of course, phase 3 is death in several days or weeks, and that's mostly caused by an infection for an injury that wasn't properly maintained early on. So CERT members, we need to work quickly, and we need to work efficiently to help as many people as possible. 40%, over 40% of people that survive do so because they received simple and rapid treatment early on. And that's what we are there to do. And like the slide says, this is real, and the data proves it. I think the most important lesson for all of us to take away from this tonight is if you come across a victim with any of the 3 killers, they're sick, and consider them to be sick, and they need to be treated. And like I said, the more quickly we can get to them, and the more quickly we can get even simple treatment to them, or first aid or bandaging or whatever, the better it is for us and them. So just make it happen. And I'm confident that we can all do it. Approaching a victim, and this is very important. The number one thing I always teach in class, and we go over this time and time again, is to protect yourself. As a CERT team leader, as a group leader, as an incident commander, the worst thing to happen is having your own people get hurt or injured on a scene, because then all your resources have to shift, because we take care of our own first. So protect yourself. Is the scene safe? That's the biggest thing. If you don't think it's safe to go in, then don't go in. If you're uncomfortable, don't go in. But if the scene is safe, always protect yourself, always be aware of your surroundings. Make sure you introduce yourself. Hi, I'm Mike from CERT. I'm here to help. Most importantly is be yourself. Be confident. Just remember, it's not your emergency. Most people that are injured are happy to see somebody there to help them out. If you remain calm and confident, whatever your level of skill is, psychologically, you're helping that person out immensely. So just remember that psychological first aid is really, really big. Of course, legal stuff, again, we go over this all the time, but we haven't seen each other in a while. So be sure you always ask and request permission to treat an individual, no matter what their injury. If they're unconscious, this is implied consent. What we mean by that is if the patient was conscious and you ask them to help, they would definitely give you their consent. If they're unconscious, and so we assume then that they had given you implied consent, and you may treat him or her. I had a question raised to me one night when I was teaching CPR. In fact, it was just a couple of weeks ago. We were talking about just this, implied consent. It came up when a choking victim who has an airway obstruction passes out, and you start CPR. And I don't know how we got on the subject, but if a person's giving you a hard time and they don't want to be treated and their injuries are severe, they're going into shock and they pass out, now you have implied consent. So go ahead and treat them. With children, make sure you ask a parent or a guardian permission to treat. Now, again, if there's no parents, there's no guardians there, you can again use implied consent. In that, if a parent was present, they would definitely give you permission to treat their son or daughter, but be sure you ask the child, regardless of their age, if it's okay to take a look at their injury.
May I make a comment?
Sure can. Go right ahead.
If you are in that situation where there is no parent or guardian and you have a minor, that's where it's really important that you have your CERT buddy or team leader or someone else there with you, because dealing with minors comes with a whole raft of issues. So you want to make sure that both you and your buddy are there with the child, and the child is never left alone with an individual. Make sense?
Right. Yes, it does. Thank you, Judith, for that. Of course, we always work in pairs, right? I ever want to see a CERT person running around the scene by themselves. You always have your partner with you. Just remember that all medical patients are legally entitled to confidentiality. It's called the HIPAA. Doctor's offices, even today, every time you go for a visit, make sure that you have your HIPAA forms on file, that you have your permissions on file, that yes, my wife can look at and can ask about my medical history, and I hers, and my children, and you have to sign waivers, and they still ask you that every time you go to the doctor. So it's very, very important. And when you're dealing with people, you don't want to speak of their injuries in a manner that others can hear. Respect them and respect their privacy and their medical condition, especially if they have underlying circumstances that maybe they're embarrassed about. You don't want to be repeating those in a tone or a volume that others can hear. So just remember, confidentiality is a big thing when we deal with medical patients, whether we're CERT or EMS or the fire department, and so on. So just be careful about that. This is a big one now with cultural considerations. A lot of Muslim nations and cultures, you cannot treat a woman for an injury unless her male counterpart, husband, or whatever is there to give you permission to treat her. So you have to be really, really careful of cultural considerations. And like I said, we have more and more of that today, right? We're becoming an integrated society. So we have to be very careful of others and their health considerations. Again, dangerous situations. By this, I don't necessarily mean is the scene safe, but I mean by, is it a crime scene? Was it a domestic? Was it an assault or a rape? You may encounter that, you may not, but please, if the situation is dangerous, be on your guard. If it's anything like that and you suspect it, always try to have a law enforcement person there if we can. Again, we may not because of the time constraints, the size of the incident, how long it's going to take officers to get there, because again, they're going to be very, very, very busy. But just please be on your guard all the time. Watch out for yourself and each other. That's why you have a buddy. Your buddy watches your back all the time. And this one happens a lot, where most people want to be seen only by somebody in a uniform. I didn't realize this until I became involved in the EMS and the fire service, how important sometimes that can be. So just like I have here on the bottom, grab your green vest and get to work. It is considered a uniform, a service uniform. So, and again, a lot of people psychologically, when they see a uniform, whether it be fire, EMS, police officer, us wearing our green vest, it's a very, very good situation for them to see someone in uniform. Psychologically, it could be great for them, and it could be great for you because you'd be able to handle a patient a lot better. Okay, the ABCs of life. Of course, we have airway, breathing, and circulation, or shock. Used to be called the ABCs. Now they call it the airway, breathing, shock. I still call it ABC, just an old habit, but they are all killers and they are all interconnected. And as we learned in our class, you can see that how diminished airway leads to diminished breathing, which leads to diminished circulation or shock. And we'll get into all of them. And number one, airway obstruction. A blockage of the airway is an immediate threat to a victim's life and is a true emergency. Yes, it is. Some of the typical causes that we may deal with are the tongue, foreign body obstructions, which those who took CPR with us know that foreign body obstruction is a real problem. And of course, trauma. And what I mean by trauma here is blunt force trauma. Trauma or an injury to the head, neck, or chest that inhibits the function of the respiratory system. An automobile accident, debris falling on a person is a good example, or good examples of a traumatic injury that may cause an airway obstruction. I remember when I was growing up as a kid, my mom always used to say, "Oh, you're going to swallow your tongue." But do we really swallow our tongue? Anybody know for sure?
Oh, you don't?
Yes, we know.
Not really, but that's what they always used to tell us. You're going to swallow your tongue. But anyway, just to give you a little bit of the anatomy of the airway, I'm not going to go over every one of these. I'm not a good biology teacher, but just to give you an idea how it works. You have the nasal cavity, the epiglottis, the pharynx, the larynx, the trachea. The trachea is the one that we worry about a lot. Obstructions to the trachea or a deep airway obstruction. Usually those occur in CPR situations where you have food or an ingested item in children. It could be pennies or coins or marbles or whatever. And of course, the diaphragm and the left and right lungs. So. The big fat tongue. Most common airway obstruction that we are going to see in the kind of patients that we're going to be dealing with in a situation, a multi-casualty situation when CERT gets involved. Without sufficient muscle tone, a relaxed tongue falls against the back of the posterior pharynx. So it is like swallowing your tongue. As you can see from the picture below, it does block the airway, especially when the patient is unconscious. The muscles in the body relax, they lose control, and the tongue falls against the epiglottis, or the pharynx, I'm sorry, causing an airway obstruction. So how do we fix that? Or how do we know that's occurring? Snoring respirations. Now, can anybody tell me, and I know this kind of gets into CPR a little bit, what snoring respirations or is the same as agonal respirations? I don't know if anybody knows what agonal respirations are. Snoring respirations could be a true inhibited airway. Agonal respirations, if you hear that phrase used by EMS personnel, those are not real breaths. Agonal respirations are what they call death breaths. They're your last breaths before the body totally relaxes. And this usually occurs in a full cardiac arrest. But it's two different and distinct types of respiration. So you'll know the difference. Look for a diminished airflow. Look, listen, and feel. This is something that we teach in CPR also. Look at the chest, look at the abdomen, put your hand on the abdomen, listen, feel. I usually put my ear down close to the person's face, and at the same time I'm looking across the plane of the chest. I listen with my ear, and I also feel air with my ear. So look, listen, and feel. If there's no airflow, you have an airway obstruction. Now, start basic CPRs in parentheses. If we're in a triage situation and we're doing the most good for the most people, we are not going to start CPR. CPR is labor intensive. It's time consuming, and you have to do it until someone of a higher medical authority gets there to help you or to take over for you, or you become so exhausted you can't continue. So now we've lost you and your partner and probably a couple other people to a single patient rather than helping others. So just remember that if there's no airflow, and we'll get into this in a minute, you move on to the next patient. And again, a blockage can occur in any position, so get them on their back if you can. The head tilt, chin lift maneuver. This is how we do it. We practice this all the time. Place the victim on their back, but make sure they're on a hard surface. It sometimes makes it a little bit easier. It gets the spine in alignment, and it helps you with the tilting of the head. That's if you can get them on a hard, flat surface. At this point, if you have no respirations, technically they're not breathing. They may not survive. Yes, you sometimes have to worry about cervical spine injuries, but in a case like this, I would move them and try to get the airway open. Just place one hand on the forehead and then downward pressure. Tilt the head back and put two fingers of the other hand under the bony part of the chin and lift the jaw. And that should open the airway. Head tilt, chin lift maneuver. Now there's also the jaw thrust maneuver, which I don't have a slide for, and I should have, and I apologize. If you do suspect a spinal injury or a spinal cord injury or a back injury, you get behind the patient and you put your hands under the jaw and lift it back. That's a little bit harder to do, especially for people with small hands, but it works. But I'd rather head tilt, chin lift. If breathing has restored, clear the airway, and it must be maintained. Option number one is always ask another person to hold the head in place for you. Now, in our situation, who could do this for us?
Your buddy.
Your buddy, exactly. Now, if you won't want to sacrifice your buddy and you're in a triage situation and you have multiple patients, who else could do this for you? How about one of our walking wounded or our greens? Give them something to do. Perhaps they have a partner there, husband, wife, friend, or neighbor. Ask them if they could maintain the airway for you. Give them something to do if they're willing to stay. Might take care of another patient for you. Option two is place a soft object under the victim's shoulders to elevate the shoulders slightly. That works if you have the items to do it with. Because remember now, we may be in a disaster situation. If it's in a building and there's a lot of insulation around, you can roll some insulation up and put it under their neck or the shoulder and see if it'll maintain the airway for you. If it works, great. If they have a rash later, oh well. We're not worried too much about that at that point. So again, option one, if there's somebody there that can give you a hand, ask them to do so you can move on to the next victim. If not, see if there's some supplies around that you could maintain the airway by keeping the head in the open position, the airway in the open position. It's kind of getting ahead of myself here, but during triage with multiple victims, if breathing is not restored, again, what do? We try the head tilt, chin lift maneuver a second time. Do it once. If you don't have a result, reposition the head and try again. And if you still don't get any response, then you move on to the next patient. And anybody tell me what we tag them? What color tag do we put on a person that we can't establish an airway? Black.
Come on, everybody knows this.
Black.
Yeah, black, unfortunately. But yeah, you have to move on. Remember, the greatest good for the greatest number, even in triage. And I say this every time we teach this, this block in our academies, is that triage is one of the hardest things to teach people. If you haven't done it and you haven't experienced, it's very hard to imagine what true triage really is and how you have to move and and you have to remain detached from the whole situation. And psychologically, for some people, that's a very hard thing to do. But again, we have to do it. And if it's something that you're having a hard time with, please let your team leader know, and we can get another team in there or somebody to help you out, so we can get the job done as a team. But it is very hard to teach people to leave someone to move on to the next patient, and they have to tag them black that they're not dead. And I know that, but again, it's part of our business, and we got to keep going. Let's see. Anybody have any questions at all? No? Cool, we'll move on. Bleeding control. Bleeding or hemorrhaging, of course, it's a loss of blood. And could be an interior closed vascular system, or it could be a result of a multi or an MOU or an MOI.
What's
Types
an
are
MOI? What's an
mechanism
MOI?
of mechanism of injury. I'm sorry.
Huh.
To a result of a mechanism of injury. Again, automobile accidents, falling debris, knives, chainsaws, cuts, razors, scissors, pencils, pens, gunshot wounds. It all depends on what the mechanism of the injury is, what type of hemorrhaging or loss of blood you're going to get. And open and closed. Internal injuries are closed vascular systems, and external is arterial, venous, and capillary bleeding, which we can see. Of course, if we have an interior or a closed vascular system bleed and you're doing your head to toe assessment, you're going to feel it, and it'll be rock hard, usually in the abdomen or the soft tissue areas. It'll feel like a ball, and you'll know that you have an internal bleed, probably from an organ that was damaged by blunt force trauma or something along those lines. Arteries transport blood under higher pressure. So an artery will spurt, and that's true. I have seen some arteries really bleed, and they do spurt. Anybody know what color that blood is? Can anybody shout that answer out? What color?
Red.
Bright red. Very good. As opposed to, what's a venous color? Venous bleed is what color?
Darker.
Darker. It's purple. Why? Does anybody know?
Less oxygen.
Less oxygen. Very good. It's dirty. It's going back to the heart and the lungs to be cleaned and repressurized to go back out to the body. Venous bleeds, because they're under lower pressure, will flow. They don't necessarily spurt. And of course, capillary bleed are very low pressure. Capillaries are the blood vessels closest to the skin, and that just oozes. Can anybody tell me what a good capillary bleed would be? How would you
Paper
get it?
cut.
Not so much a paper cut.
Road rash.
Road rash. There you go.
Good girl.
Yeah, motorcycle injuries. A lot of road rash. Capillary bleeds are very require a lot of attention quickly, because what we've done is we've taken the skin away, and of course the biggest organ in the body is our skin, and it's designed to protect and regulate our temperature and protect us from losing everything, innards. But when you take the skin away, you have no protection anymore. That's why they become so crusty and so discolored so quickly. The body's trying to replace what it lost. So capillary bleed, they just kind of ooze. They just kind of hang around, but they're just as dangerous as the other two. Infections are more common in capillary bleeds than the other two. And there you go. Arterial bleeds, venous bleeds. and capillary bleeds. It's my favorite, hand injuries.
I wonder why.
Yeah. So what do you, when you're doing like a triage, you're looking for one, uncontrolled bleeding. Okay, that we have to maintain. We have to take care of immediately if we can. Do the best you can. How much time can we spend on each patient? Can anybody answer that? In a triage situation, how much time are we allowed to spend on every patient?
Come on, you all know that.
Is it 5 minutes?
Yeah.
3.
3.
No, come on,
No.
think about it.
It's less.
3
It's-
minutes?
It's
2
what?
minutes. It's 2
Nope.
minutes.
Yeah, 1
I
minute.
can tell it's been too
1
long since
minute.
we've done this, Mike.
Yeah.
Oh my gosh, yeah.
30 seconds to a minute,
Oh yeah.
and then you roll on.
Oh,
But if you have a severe bleed, it's one thing you want to look for. Signs of shock, which we'll get into because that's the next killer. Of course, the nature of the wound, and this goes back to the mechanism of injury. You know, if you had a tornado or a hurricane go through a building, you're going to, you know, what kind of wounds are you going to be looking for? You know, contusions and lacerations, and so you know, you're pre-planning before you even get into your triage situation. You kind of know what kind of injuries you're going to have. And of course, the depth of the wound would indicate if it's controlled or uncontrolled bleeding. But that's some of the things we're looking for. So how do we stop it? The human body has an amazing property called clotting. Has anybody ever looked at a gauze bandage really closely?
Yes.
Yeah, and gauze bandages, how they're woven and knitted in indirect crisscross square patterns. They're designed to trap, collect, and clot blood. That's why they're designed the way they are. It's more conductive surface for the blood to adhere to, so it helps the clotting process. That's why we never take a bandage off a wound that we are trying to stop the bleeding on. Okay, you know, if it's bleeding through, what do you do?
Put more on. Just
That's
put
right.
more
I
on.
heard it. Put more on, and then don't ever take it off. And you know, that used to make me upset when I get to a hospital as an EMT and a paramedic, and I'd roll in there with a patient that's all bandaged up nice and neat. And what's the first thing the nurse does? They start cutting everything off. And then they say, "Oh, he's bleeding." Yeah, you think? Of course he is. But anyway, so direct pressure. They're easy to halt. Capillary and venous wounds are easy because they're under lower pressure, remember? Arterial bleeds are a little bit harder. You have to put more pressure. And when I say pressure, I mean push. If you think you have an arterial bleed and you're applying direct pressure, don't be afraid to hurt the person. You might even want to tell them this might be uncomfortable, and push as hard as you can. And then wrap it with a pressure bandaging. I mean, you put your bandage on, you always tie the knot over the wound. That even helps you more, put more pressure on it for you when you move on to your next patient. And of course, tourniquets. A lot has changed in the world of tourniquets, especially over the last couple of years. And we'll get into tourniquets in the next couple of slides here. Before we do that, about bleeding, I want to talk a little bit about our personal protective equipment, or PPE. You'll hear people say, you know, in the fire service and EMS service, they're big on acronyms. Our PPE is, you know, my bunker pants and my coat, my helmet, my boots, my gloves, my goggles, my hood. At the minimum, you should have gloves and eye protection whenever you're working on a patient. We are all issued gloves, goggles, and masks. I would expect all of you to wear your masks and your gloves and your eye protection at all times when we're operating on the scene. I said this before, protecting ourselves is the number one priority. It's the number one priority for me also. I do not want to have to write a report, although I would if it happened, for someone that got hurt on a scene. And it's going to happen, you know, especially, you know, when we're expected to be in post-hurricane or post-tornado or a post-derecho in there trying to clean things up. It's not going to be easy going, but protect yourself. That's your number one priority. Scene safety. And just think about your friends, your family, and your loved ones. You know, when I was a fire chief up north, we'd have a fire and guys would come to me, especially the younger guys, the younger kids actually, would come to me and say, Chief, what'd you pull us out of the fire for? We were making good headway and yada, yada, yada. And I'd let them spout out and get upset and carry on. And I just say to them, are you going home tonight? Are you going home to your family and your friends and your loved ones? Yeah, okay, that's why. Sometimes on the outside, you see things that they don't see on the inside because they're all hepped up and want to get in there and get the job done. But think about that. Take care of yourself for your family, friends, and loved ones. They need you. They need you more than I do. So direct pressure. Here we go. Place the direct pressure right over the wound, putting the clean dressing over the wound and pressing firmly. And I said this earlier, push hard, especially if it's an arterial bleed. And again, you might want to tell them it's going to be uncomfortable. This is a situation where you might ask the patient to be a helper. I have to do this a lot because of my circumstance. I'll ask them to hold it while I go get the rest of the stuff ready. Have them maintain the pressure on the bandage, and so I can get the material to start wrapping it up with, so I can finish it, and tie it off. When you tie a bow and bandaging, sometimes it's hard. Ask them to put their finger on the knot before you make the bow. Any of these little things that you can have them do sometimes takes the pressure off of them. They feel like they're helping out and they're doing something and they're helping you, and it kind of takes their mind off the injury, and they're doing something, constructive for themselves. Okay, let's get into tourniquets. Oh, I forgot to talk about elevation, direct pressure and elevation. Elevate above the heart. What's the first thing they do when you give blood and they take the needle out? What do they have you do?
Put your arm up.
Put your arm up. Raise your arm. They put a little bit of they put a little bit of gauze on there and they say, hey, can you hold this, please? And they put your arm up. Well, gravity works wonders, and it does in the body also, and it does work. So direct pressure, elevation, and then we'll get into tourniquets, because we're not teaching too much in pressure points anymore, believe it or not. Of course, you have your brachial artery and your femoral artery and your pedal artery. Pressure points, we do a lot of that in CPR because we use that for observation and result, but they don't really teach a lot about pressure points anymore. And that's been a change now since we've gotten more into the use of tourniquets. Although they say in the first slide here that if you use a tourniquet, if direct pressure fails and the pressure bandage fails, again, if your wound is bleeding through your bandaging, just keep putting more bandaging on top of it. Don't take it off to see what's wrong or see why it's not stopping. Just keep adding, keep tightening, and hopefully it'll stop for you. Usually when you put a pressure bandage on, it takes about 5 to 7 minutes for the clotting process to start if the bleed is heavy. So keep on it, or have them keep on it. Move on to the next person. When do you apply it? If it's an automobile accident, we do it prior to extrication. If it's a CERT activity and we're in a building collapse and we have to move some debris, or we have to wait for somebody to move some debris off a patient, do it prior to that extrication. Definitely do it prior to transport. If it's serious enough, get it done right away. And obviously before the onset of shot. And this is a clear advantage to everyone, the patient and us. I don't know how many of you have taken the Stop the Bleed program. If you have not, it's a great, great program. You actually get to put a tourniquet on each other, and they hurt. You tighten it until the bleeding stops. Can you use a second tourniquet? You can. Anybody tell me where you would put a second tourniquet?
Next to the first.
Next to the first one. Usually say an inch or two above the first, you put the second. Personnel, yes,
Can I ask a question?
sure can.
And this, I legitimately don't know the answer to this.
Okay.
But I can surmise. If we are CERT and we are walking through a building performing search, rescue, triage,
Okay,
and we come upon someone who has had an arterial bleed, a serious arterial bleed, and it's been 30 minutes from the time we were called and we arrived, or maybe an hour, or maybe 2 hours. What are the chances that that person with a serious arterial bleed is still alive?
if it's a serious arterial bleed, they're not. The body holds 5 liters of blood, give or take a little bit, depending on condition, size, weight. Technically, if you lose 1 liter of blood, you're in trouble. That's a diminished supply. The human can bleed out from a serious arterial bleed in 5 to 7 minutes, 4 minutes, depending on the arterial bleed. If it's a femoral artery, it can bleed out in 4 minutes or less. So if someone has a severe arterial bleed and they've been down that long, they're probably not going to survive, or they have already perished. Of course, you
So
would have
with the
to.
new CERT curriculum, or with the changes that are coming or have been made,
Mhm.
is it common practice for us to carry tourniquets with us as we do search, rescue, triage?
Yes, because they are teaching the use of tourniquets now, and we are in the new classes now. We will be doing tourniquets, and as part of the Stop the Bleed, which has been not a part of the CERT, but it's been recommended by the CERT program for our people to attend. We will be using tourniquets.
So we are not prohibited from taking tourniquets with us and using them if
No,
we feel it's necessary as we do the search, rescue, triage.
No, we are not. We can
Great.
use them.
In the previous, a lot of you have took the CERT training several years ago or more, and we were not allowed to do that. So this is a change that
Yes.
everyone needs to be aware of.
Yes, even when I took my original class only,
Mhm.
oh geez,
Yeah.
7 or 8 years ago now,
Mhm.
or a little bit more, we did not teach tourniquets. But now with today's society and the types of injuries and mass shootings in schools and everything else, they've introduced tourniquets back into the CERT program. So yeah, and then again, if you're Stop the Bleed, you can use them. And if anybody hasn't taken that class, we have 2 instructors now that are Stop the Bleed certified in our CERT program, and I have 2 Stop the Bleed instructor kits. So when we can start getting together again, we'll be offering that. I have to talk to Sarah about how many numbers and how many students I can have in one class. Maybe we can start now, but I'll let everybody know. And again, you tighten the tourniquet until the bleeding stops. Now, for those of you who went to Stop the Bleed or ever had a tourniquet applied to you, or had to have a tourniquet applied to you for some reason, they hurt. Especially the new ones, the ratchet style military quick set tourniquets. You go 2 or 3 or 4 clicks on that ratchet, and you know you have a tourniquet on. And be sure you tell the patient that it's going to hurt. Obviously, the sooner the better we transport them to the hospital is better for the patient. Obviously, because the hospital has surgical capabilities that could take care of the problem. Document the time of the application, and this is very, very important. When you apply a tourniquet, somewhere on the patient or on the tourniquet. Now, in the new tourniquets, they have a spot right on the strap that is there for you just to mark the time that you applied the tourniquet, so that when they get to a hospital or an emergency room or a field hospital, everybody knows how long that tourniquet has been in place. And that's really important for trauma centers and hospitals to know how much time they have or how much time they've lost to get this patient into surgery.
Mike, may I ask a
Yes.
question?
Sure can. Go ahead, Pat.
The ratchet type tourniquet, is that easier to use for someone who doesn't have a lot of power in their hands?
Yes, I would say so because you're not pulling in against the arm and you don't have to hold the limb and then stretch the tourniquet. Like we have some elastic ones that work very well also. The ratchets, although they get very hard to turn once you start getting tighter, but I think they are easier to use. And those ratchet styles you can do on yourself. You can deploy the tourniquet yourself on yourself. So they're a lot easier to use. Yes,
Okay, thank you.
they're a lot easier to use. It's a safe procedure now, can be performed or should be performed by all providers, and it does save lives. And again, if the first tourniquet's not working and it doesn't sufficiently stop the flow of blood, apply a second one. And again, I can't say this enough. When you apply a tourniquet on a person, especially these new ratchet style, quick military style, quick tourniquets, it's going to hurt. And it's going to hurt. And when you take the Stop the Bleed class, if you want, take it. We'll apply one on you, and you'll see just how much it does hurt. But anyway, enough of that.
Hey,
I don't wanna
Mike,
hurt you. Yes, sir.
one of the things that I'm sure you're going to do if you have someone that you have to put a tourniquet on is you're going to have to treat them for shock by keeping them warm. And that tends to cover where the tourniquet's been applied. So you need to mark the body somewhere on the outside to let anybody know that there's a tourniquet applied, especially, when they're evacuated from your area. And I would put a big T on their forehead.
Yeah,
Right,
good one.
right on the forehead.
Yep.
That's not it.
That's why I carry Sharpies in my backpack. I carry a red, yellow, green, and black. And if I don't have any tape, I mark them on the forehead.
That's not it.
That's a
Yeah,
good
I
thought,
think
Jack.
that's really important.
Yeah.
You have, yeah, that's a good point, Jack. Thanks very much. Thanks very much. Place a tourniquet between the wound and the heart. That's obvious. We do that with all bandaging, but if you have a cut wrist, you would place it on the forearm just above the cut. I find it ironic that we're using a cut wrist here, Jack. Wow, I didn't realize that until just now. But and yes, I put the tourniquet on my forearm.
Oh,
And this is the old style tourniquet. This what we're showing here. If you don't have anything fancy, you take it's the 2x2 rule. You use 2 knots and a stick and a pen. You wrap the material in the area that you're going to use the tourniquet on, and don't use this shoestring or a piece of rope or a boot lace like I used in my case, but that was all I had back then. What they want you to use now is something that's about 2 inches wide or an inch to 2 wide, that you can wrap around the area, tie it really tight, and then you take a stick, a pen, a ruler. And in my case, I used a piece of scrap wood. You tie a knot around that next to the knot that you tied on the tourniquet, and then you start winding it. Of course, now in the old style or the handmade tourniquets, you don't have that ratchet. So when you're winding it down, you don't have the ability for it to hold. You got to hold onto it because it'll snap back at you once you start getting it really, really tight. So there's no ratchet to hold it in place. Even on the ratchet styles, they have a safety on them. You tie the stick to secure it, and then you tie one or both ends or wrap one or both ends of the stick that you use to make your windlass around the limb to help secure it, to maintain pressure. So you never want to let it go. Once you get it tightened down as tight as you can get it, tape it or wrap it, use a cravat, use some gauze or anything to tighten it down, to keep that windlass, to keep your homemade ratchet from releasing the pressure. Jack, here you go. Mark the patient in an obvious way. Forehead's a good place. Indicate that a tourniquet was used in the time of application. Folks, don't be afraid to do something like that, right on the forehead or on the patient somewhere. It's going to make it very easy at the hospital, and for others to know that you have a tourniquet applied. Once you apply it, will never, ever loosen a tourniquet. Old school, years ago, we taught tourniquets, and then they went away from tourniquets, and now we're coming back to tourniquets. But years ago, we used to relieve some pressure every 10 minutes in order to try to preserve the tissue below the injury. We don't do that anymore. Never loosen a tourniquet. Once it's on to stay. You may lose the limb below the tourniquet, but you may be saving a life. And that's what it comes down to. Like in my case, I may have lost my hand, but it saved me. I'm here today. So only proper medical authorities should ever remove a tourniquet. They won't touch it until you get to the hospital with them. Medical personnel and paramedics in an ambulance will not loosen your tourniquet. They will not take it off. They wait till they get to a trauma center that has the operating room facilities to deal with it, and proper medical personnel and equipment and all that kind of stuff. So because there's a lot of toxicity that can build up in the limb, and I won't get into all the chemistry. When you diminish the flow of circulation and the return of bad blood for recycling, you get a lot of toxicity in the lower limb, the limb below the tourniquet, and that's why we don't want to ever take them off. You can go into septic shock really, really quick if that happens. It's called the smiling death syndrome. Any questions at all on tourniquets at all? I know we kind of went through that pretty quick. Yes, I hear a question.
I have a question, Mike. So
Sure.
I don't remember, I know we covered this in training, but I don't remember the answer. And it sounds like one is probably going to lose the limb beneath the tourniquet, but not 100% of the time. Is that correct?
Yes, that's correct. When you get to a hospital, they may be able to restore circulation through surgery because they do a lot of microsurgery now. The limb may be damaged to some extent, but they may be able to save the limb itself. They always don't have to finish what you started. A lot of times they can finish it. It's always been my, I guess, assumption, which I shouldn't probably do, but you can never really stop all of the bleeding 100% of the time with a tourniquet. If the limb is still attached, you're still going to get some flow. And you might get some return through a vein. I can't back that by science or statistics, but they have been able to restore limbs that have had tourniquets applied. I'm a perfect example of that. So yeah, I would say for reconstructive surgery now, they can do just about anything. So I'd say there's a good chance they could restore it.
So
Again, depending on the injury.
So if they're still bleeding beneath the tourniquet, I know you talked about a second tourniquet. Could we also try packing bandages and on top of that and adding pressure, or no?
Oh yeah, you can always wrap it. You would wrap it. I would wrap it anyway, just to protect it from debris, infection, anything like that. I would and try to protect the tissue that's still viable. Yeah, I would still wrap it. Yeah. Yep.
Thanks.
You're welcome. Any other questions at all? Okay. Killer number 3, shock. Of course, a simple medical definition is state of inadequate tissue perfusion. To us, that means that the body's not getting the blood supply where it needs to be. The body has a really, really unique way of taking care of itself. When you go into shock or you have an injury and the body starts to shut down, it pulls blood and circulation away from the limbs and extremities and focuses it more towards the core of your body, heart, lungs, brain, head, to try to maintain the body's functionality. Yeah, somebody have a question? No? So the simple medical term is a state of inadequate tissue perfusion. All that means to us is that the body's not getting the blood and the oxygen and supplies it needs to maintain itself. It is right there. The body's not getting enough blood flow. The underlying killing of trauma patients is often subtle until the body can no longer compensate. That's the hard thing about shock. If we don't recognize it right away, or people don't recognize it right away, a person can change on you in a matter of seconds. A simple example is that they pass out. The body can't maintain anymore. They go unconscious. They pass out. because the body is starting to pull all that blood to the core. Medical shock, though, is different from emotional or psychological shock that can occur following an injury. The killer is not someone who is shocked, okay? You can have electrical shock, which is not medical shock. The one we're dealing with is blood doesn't circulate. It's right here. Oxygen, other nutrients are not carried to the tissues and organs. Blood vessels begin to close and organs become damaged. If left untreated, shock will shut down completely, and it can worsen very rapidly. I hate to read it right off the slide, but that's what happens. The body starts to shut itself off. It starts to protect the vital organs to try to save itself. Different types of shock. We have septic shock, which results from bacteria. Sepsis, you hear a lot about people getting septic shock from being in hospital locations, believe it or not. Septic shock occurs, especially when you have tourniquets applied. It's called a crushing death syndrome, when that toxicity builds up in the blood that's not circulating properly behind a tourniquet or under a lot of pressure, like a collapse or an automobile accident, and the organ or the limb is suddenly released from pressure, and you get that those toxins into the system. That's septic shock. Anaphylactic shock. What's the number one anaphylactic shock we probably see?
Bee sting?
Plastic gloves.
Yep, bee stings. And that's why we have our EpiPens. Hypovolemic shock caused by blood loss, such as trauma. This is the big one if you have a lot of hemorrhaging. It's hypovolemic shock. Hypovolemic shock, I'm sorry. The heart is unable to pump enough blood to the body to survive. Cardiogenic shock happens when the heart is damaged and unable to supply sufficient blood to the body. Cardiogenic shock, cardiac arrest, a heart attack. There's an underlying cause. You don't know if it's an obstruction, a blockage. That we can't see. Could be a dislodged artery. Could be a lot of things. Could be a valve problem. The body the heart's not able to supply enough supplies to the whole body. Neurogenic shock is simply caused by an injury to the spinal cord, and usually results from a traumatic injury or an automobile accident, or in our case, if it's a hurricane or a tornado, they may have been involved in a debris field and got hit by some debris or something like that. Signs and symptoms. This is what we have to pay attention to. Rapid, shallow breathing. Normal people believe 30 to 60 times a minute. If their breathing is rapid and shallow and it's above 30, take a look at them. Capillary refill is a big one, right? Greater than 2 seconds. What else can we use if a capillary refill is not possible? It's called a Blanch test. Where we don't do the capillary refill, we'll pinch the skin somewhere on the hand, usually in the palm of the hand or the back of the hand. And if you don't get a capillary refill within 2 seconds, that's a good sign of shock. Check for a real rapid radial pulse. If what we used to call light and feathery. If it's rapid, light, and feathery, it's either going 120 or 130, and you're having a hard time finding it, that's a good sign of shock. Mental status. Are they able to follow simple commands? And we do this a lot. Just squeeze my hand. Hey, what day is it? We do a rule where it's by 3. Ask them 3 questions. What's your name? Where do you live? Can you squeeze my hand? And as you start treating the patient, 10 or 15 minutes later, you ask them what their name is. You ask them again, what's your name? What's your address? Can you squeeze my hand? Can you move your hands? Can you move your feet? Just simple commands. If they can't follow simple commands, that's a good sign of shock. Skin signs, sweaty, cool, pale. If they look sick, they probably are. This is big in cardiac or cardiogenic shock, sweaty, cool, and pale. Look for lips that are cyanotic, blue or grayish color. Really, really good signs of shock. Hey.
Comment.
Yep, go ahead, Marianne. How are you?
Hi. The whole thing about the capillary refill, something to keep in mind is that a person can have a medical condition that that's a normal problem. You know,
That's-
I have that problem, so I walk
So-
around with white hands all the time.
So we do a Blanche test on you. And that's a good point you bring up. People of color also have a hard time doing a capillary refill test on people of color. Children, it's hard to get a capillary refill, an accurate one. So do a Blanche test on children. If it's really cold outside and their hands are cold, you might not get a real accurate capillary refill. So I would go for the rapid pulse then, and the commands for and breathing for shock.
Mike, what's the Blanche test?
Blanche test is when you take the palm of your hand and you take your other hand and you squeeze a piece of the tissue on your hand,
Okay,
and you squeeze it hard and you let it go, and you'll see it change from white to red.
okay.
It turns back to pink. You can do it on the forearm. You can do it on the palm of their hand. You can do it on the back of their hand. Any place you can grab some tissue. That's called a Blanche test. Good question, sir. Let's see. Okay, step one, we always lay the patient down on their back if we can, to maintain their and maintain an open airway. Remember now, if they go into shock and they go unconscious, what's going to happen to you? You're gonna have a problem with their airway. They lose consciousness, and yep, you will.
Tongue's gonna relax.
Yep, tongue's gonna relax. So lay them down on their back, maintain an airway. So keep an eye on their airway. Obviously, control the excessive bleeding. Like Jack brought up earlier, maintain body temperature. One thing about body temperature, if you have only one blanket, sometimes it's better to put the blanket under the person to maintain temperature than it is over the person, simply because you want to interrupt that thermal dynamic between the body and the ground. The ground, if it's cool and damp, will actually draw heat from the body. So sometimes it's better to put the blanket or sheet or whatever you have under the patient rather than over the patient. Now, if you have both, that's great. Elevate 6 to 10 inches above the level of the heart to assist bringing blood to the vital organs. Remember I said earlier, when the body starts going into shock, it starts pulling the blood toward the core organs. So we can help it out a little bit. Just keep your feet up. Let gravity do its thing. And keep the blood down to the vital organs. But just remember that if you lay them on their back and they go unconscious on you, make sure you're maintaining that airway. You may have to do the head tilt chin lift, and you may have to open their airway and have somebody maintain that for you. Any questions at all? No? Well, that's it, folks. I hope that was entertaining. This is our first Zoom class. I hope it went well. If you have any questions that you think about later on, let me know. Let me see if I can close this out.
Real
Mike.
quick.
Mike,
Yep, go ahead.
Mike, the ratchet tourniquet, where can you get those?
H&H Medical.
Oh, over on McLaw's?
On McCall Circle.
Oh, okay,
Gives us a really good price on
okay,
the ratchet style tourniquets.
thank you.
Mhm.
Real
I
quick,
also ordered a bunch of them from Amazon as well,
Okay,
just because I could get a good price on them.
okay. Thank you, Judith.
Hey, Mike, before you let people go, I need some names of people for our attendance roster.
Okay, Barbara,
Get
just
off of
before you,
the,
Jack,
off of the
before you
screen.
start,
I've got a
before-
Trish's mini pad. I need to know who that is.
Trish Volp,
What's the last name?
Volp, V as in victory, OLP as in Peter.
Got it.
Patricia. Hi, Pat.
Okay, I've got a Barbara.
and
There'll be Barbara and Ron Smith right here.
Hi, Barbara.
yeah, we're both here.
Did you have a question, Barbara?
No, I was raising my hand
Oh.
before you signed off to catch your attention to say we both had it.
Okay, cool. We got you.
Thank you.
And okay, I don't see the iPhone. Who's the iPhone?
Oh, that's me. Can you hear me?
Yes, I hear
Yep.
you.
Okay, I'm Lynn Miller.
Hi, Lynn.
Hello.
It could be me as well. This is Jennifer Tyndall.
Hi, Jen.
Hey,
Hi, Jen.
Well, I'll write that.
Did you get Jennifer? Was it Jennifer Tyndall? Did you get her?
I'm writing it down. Now I've got three Patricias that I may have written them down. Maybe there's only two that don't have names.
Do you have Patricia Krenka? She's on, but her mic is broken.
Okay, spell that, Mike?
CHRENKA, Patricia.
Okay,
Did you also get Kevin Bowen?
Kevin.
Kevin's here, but his mic is.
Yep, I've got
okay.
him.
Okay, great.
And
Tom Leitch.
You got Tom and Sue?
Yeah.
Hi, guys.
Hi,
Do you have
we're
the
having
spelling?
bandwidth issues, so
all right.
Having who?
bandwidth issues.
Oh,
So
no.
when there's too much.
Jack, do you have the spelling of Sue's last name?
I've got enough to find her.
Okay, it's Leitzsch.
All
And
right.
Tom.
And Sue, what was your husband's name?
Tom,
Tom.
Okay.
it's right there.
Let me go through this again. I think I've got everybody else that I can identify.
And before we all go, Mike's got another question from someone.
Okay, got everybody.
And the question is from?
Someone was asking a question and Jack talked over her. Can you come back, whoever you were?
That may have been me.
Go
That was
for it.
Barbara.
Okay. It's been answered. Thank you.
Oh,
Okay.
That was Barbara. Just letting us know she was here.
So I do have a question. This is Ron.
Hi, Ron.
Wondering as far as the link to watch this again, or how's that work?
The recording?
Recording, watch the recording?
Well, I will have the recording on my computer, and Mike and I will have to figure out some way of making it available to people. And I think we'll be able to do that. We'll get it on YouTube or someplace and let people know where it is.
I mean, isn't it going to be on the CERT website?
What cert?
Well, you probably won't go on the CERT website because it's going to be too big of a file. We have to put it on something that'll take it free like YouTube and then put a link to it.
Oh, okay.
Link to it.
Yeah, link to it. Anybody? Any